I'm Michael Mauro. I'm director of the Chronic Myeloid Leukemia Program in New York at Memorial Sloan Kettering Cancer Center. Been here for about 13, 14 years. Before that, I worked at Oregon Health Sciences University with my mentor was Brian Druker, who's really sort of the grandfather of CML therapies, targeted therapy in CML, and I helped him with the clinical trials program there. I'm a clinician scientist. I do a lot of clinical research in CML, have a trial portfolio. My heart and soul are taking care of patients with CML and developing everything from early phase one drugs for resistance and tolerance, all the way through survivorship and treatment cessation and everything in between. Actually, this year marks 25 years since Amanda was FDA approved, which is a big milestone. Before that, we had simple therapies for CML, we had stem cell transplant. The advent of Abl kinase inhibitors really revolutionized cancer treatment. So we started with Amanda, which was a huge breakthrough and really a paradigm shift, and that set us alight. And couldn't even have guessed how far we would have gone, leading to stable, deep remissions, leading to the idea that patients could stop treatment, in at least under certain circumstances, a fraction. And then since then, we've had multiple other drugs coming after Amanda have developed. Three second-generation drugs, nilotinib, dasatinib, and bosutinib. Two subsequent line drugs, ponatinib and asciminib, with asciminib being the most recent and probably one of the more significant advances regarding safety and tolerability and a leg up on optimizing treatment. And there are even some drugs outside of the US that have been developed and licensed. And we're really getting closer to higher fractions of cure, higher fractions of being able to have patients off treatment, very high rates of remission. We've already shown life expectancy to be normal in CML. And it's a pleasure to be in the clinic, with patients with CML, to be able to give them these kinds of forecasts when they're faced with such a diagnosis. So CML is actually typically diagnosed by accident. Someone goes in for another health issue and someone notices blood changes or symptoms or both, more often blood changes that indicate a possible CML diagnosis. And that often raises alarms and can be very unnerving because you've gone in for your health check and you get a call back to return to the hospital or the emergency room for a very high white blood cell count or other things. So diagnosis by a routine testing is a little less common. Diagnosis by accident is common. But once a question has been raised, most things can be ascertained from blood-based testing. However, a bone marrow test really, in this day and age, still helps us completely understand the biology of the disease, including some of the more recent nuances to us understanding, making sure we understand the capacity of the disease to be well treated or potentially to potentially lead to other complications. Meaning, knowing it's in chronic phase and it's not in any kind of later phase is really best determined by bone marrow still. The tests we do involve looking at the genetics and the molecular markers of CML, which are really showing us identifying what's called the Philadelphia chromosome, which is the hallmark genetic change which drives CML. That often raises a question immediately in patients' genetics, chromosomes. Is this something I was born with, going to pass on to children, grandchildren? No. It's something that happens in life. It's a genetic error. It's probably more common than we know, but it causes this CML diagnosis in a smaller number of individuals. So with the right, unfortunately, accidental finding, launching into proper blood-based, just examine the clinic, and then bone marrow-based testing, we should have everything we need. And simple treatment can be started, simple measures to protect someone, get their white blood cell count under some control if needed. And that's not always even needed. And then again, that careful expert care or specialty center discussion about what's my best treatment choice based on my goals of treatment, my health, my other health conditions, my the medically comorbidities as we call it. It's a lot of discussion that's really key in the first days, weeks of this diagnosis. It gets pretty simple thereafter because then it's just a matter of milestone monitoring and checking in on a regular pace. Back to the running analogy, hitting your mile markers on time. It is definitely a journey. I'm a runner, so I always use an analogy. It's a marathon. You kind of have to be prepared and to kind of pace yourself and take care of yourself along the way. It's at least a several year journey. We have to kind of prepare for the fact that it could be a lifelong journey for some or many. On the flip side, it's this oral targeted therapy, which when you're able to get past any adverse effects or some of the early adjustments. And with multiple options, most patients have a very good quality of life, hopefully shouldn't have any limiting side effects, things that are either getting in the way or, importantly, leading them to feel like they don't want to take the drug or they can't take the drug. Communication is key. In the clinic, response milestones are absolutely key to understand that we're doing well, we're on track, we're getting into relevant, safe levels of remission. We set expectations, as a team, what are our goals of treatment? But for most patients, we're able to get them out of trouble, I might say, from CML, where it's very unlikely to progress or advance or move into an advanced phase. And that's getting patients into remissions we call a major molecular remission, where the disease levels are 1,000 times below where they are when they start, or hopefully a deep molecular remission. And then there's just careful decision about whether patients are eligible and can stop treatment. And that's not always successful. So we actually have research into how to try subsequent times to, subsequent attempts to try to get patients into a point when they don't need treatment indefinitely. Absorption of a drug can be erratic if you take it with different foods, particularly actually if you take it with something rich like a fatty meal. So unfortunately, some of the drugs face this challenge. You have to take them on an empty stomach, so you get the right amount absorbed. You may have erratic drug levels, often more absorption than you want, which sounds like a good thing, but may not be a good thing. And that can be a challenge because it requires timing and forethought, and especially if you have a twice-a-day drug with fasting, that's a challenge. Fortunately, we have very good drugs which are once a day, which need a fasting requirement. We have drugs that are very good that have been available for a while that aren't. Don't have any food requirements, although they may have, for example, requirements where you can't take them with antacids or acid blocking drugs. So we have other limitations. And then there's this whole space that's opened up developing alternative forms of our available drugs, which are the same as the drugs we've been using, but they don't require fasting compared to the prior version, which did, or they're not going to require restrictions around taking acid blocking or heartburn, treating drugs. Those drugs won't interfere with the absorption of some of these newer forms. So it's a reality, but it's something that we're able to, even without newer drugs, able to manage as long as we talk about it and think it through and pay attention. But the good news is we have advances coming where we should be able to even be able to be bothered less by those restrictions. So newly diagnosed CML is probably a curveball for most people, or a freight train that came out of nowhere, maybe. I don't know. I'm not sure how strong an analogy to use. So the first thing is to get into good care, to get good counsel. I don't want to be too bold on this point, but seeking expert care or a center of excellence may really be worth it. It may not be that they have to do every bit of someone's care, but they can really set the stage properly, can assess even a potential for a study or a very robust discussion on what's my best path forward, set the right course and the right schedule of monitoring, and so on. So I could go through all the elements that someone needs to be asking about, but when someone gets diagnosed, they hopefully with the help of friends, family, loved ones, a partner, a spouse, child, get to good care, get to expert care, ask questions, and then hopefully they'll hear that this is a very treatable and hopefully even functionally curable disease under many circumstances, and that with persistence and with the right guidance, they're very unlikely to succumb to CML. They're more likely to live a pretty normal life and to be able to work around it or work with it, to live with CML. I probably encourage people to say that while CML is a very treatable and hopefully even a functionally curable disease in many people, it's still serious and it's still blood cancer and it still requires a lot of attention and diligence and caution. We all have our potential pitfalls. Doctors sometimes don't always follow guidelines or aren't as aggressive about talking about side effects or treatment milestones. It's hard to take medication for several years on end, daily, without a break. So both on the provider and the patient side, we really have to aim high and stay engaged and have a high level of dialogue, because with all of those ingredients, that's where success really is the highest. For example, on our side, one of the more common reasons why someone might not appear to be responding to well treatment is they might have fallen off the wagon. They might have stopped medication, and that might have been because of a side effect that we didn't know about or talk about, or some other issue in their lives. So it's not just the roadmap and a host of drugs and a very high rate of success and high rate of remission, but it's the human side and back to good old fashioned doctor-patient relationship that's really key.